And I also wanted to mention that for the CEU credits, you that are certified Pedorthics, make sure that we have applied for the credit. Usually when we apply, we are getting the credit for the amount of units that you need for this continuing education program. So email Betty at footsolutions.com, and she will email you the test for this course, and in the completion of that test, then you will be notified as to the continuing education hours. Let me say that I have put a lot of time and effort into this presentation. I hope that you will gain a lot of insight into what I'm trying to reveal. It's not just heel pain. I think by the time you get through with this webinar, you will actually understand a little more in depth as to the heel pain syndrome of diagnosis that has been given a lot of times. Oh, hang on just a second. We're going to start really right off with the anatomy of the foot, because there is some areas that I want you to make sure that you understand in this presentation. As you all know, the foot is a very complex structure. It's 28 bones, 31 articulations. So that's one thing I want you to keep in mind. The bones, it's simpler to think of the foot as being divided into 3 regions. And while we're talking, we're going to be talking about the 3 regions. The forefoot, which is the toes, the sesamoids, and the metatarsals. The midfoot, the cuneiforms, the medial, intermediate, and lateral, or first, second, and third cuneiforms, cuboid, and navicular bones. The hindfoot is the talus and the calcaneus. And bones of the midfoot and hindfoot are collectively referred to as the tarsal bones. But I do want you to keep in mind while we're talking that this is an x-ray of a weight-bearing foot, and I want you to look at the natural God-given padding from the floor up to that heel that is naturally there to help protect the foot. You can see that most of the weight is at the heel padding and the metatarsal area. When we break down the foot, I want you to think of the calcaneus, the cuboid, which is lateral, the navicular, the talus, and the cuneiforms, the forefoot. The sesamoid area, which is nothing but a cushioning of the bones, like the patella is a cushioning of the tibia and femur. So this area, the forefoot, the midfoot, and the hindfoot is what we're going to be talking about. Keep in mind that in the hindfoot is also called the subtalar joint of the talus and the calcaneus, and the talonavicular joint, which you will hear mentioned a number of times in this presentation, is of the talus and the navicular bone, and then also at the first metatarsal phalangeal joints. The normal human gait can be broadly divided into 2 phases, stance and swing phase. Stance phase commences with the heel striking the ground and ends when the toes push off and the foot loses contact with the ground. During the swing phase, the leg swings forward and does not come into contact with the ground. The stance phase is then repeated. Stance phase makes up 60% of the gait cycle. Swing phase makes up the remaining 40% of the gait cycle. Proper functioning of the foot is required for normal gait. Weight distribution of the body is supported by the foot. We all know that, and it is transmitted and distributed over 6 areas. Now, I do want you to keep in mind and follow me on this. The 6 areas, the calcaneus in the heel, the sesamoids of the first metatarsal heads, and the second, third, fourth, and fifth metatarsal heads. During normal gait, the foot supports loads of up to 7 times its body weight, and during barefoot gait, the forefoot actually encounters 3 times as much load distribution as the hindfoot. So remember that when you're having somebody or observe they're walking with no shoes on and you notice that they have more increased pain in the metatarsal area. Just know that that area carries more weight. The contact points of the sole of the foot during normal weight bearing is the heel, the styloid process. This is the normal gauge or the alignment. The styloid process, so the base of the fifth. Then it goes down to the metatarsals, the fifth rolling off of the first, and the distal ends, fifth toward the first. That's why the plantar first ray is so important in propulsion. But remember, if there's overpronation, there is problems that occur. So when we talk about heel pain, and we're going to break down heel pain syndrome as we go, but the footwear is important, the range of motion of dorsiflexion and plantar flexion at the ankle. Also knee flexion and extension is also contributed here, along with hip range of motion. Arch support, muscle strength of the lower extremity, and also the muscles or the intrinsic muscles of the foot, the surface that they're standing on, walking on, working on, and do they have any low back issues. Plantar fasciitis with 2 eyes is the inflammation of the ligament that runs along the arch of the foot. This condition affects over 2 million Americans. 2 million. The sufferers experience an intense stabbing pain in the heel. Heel spurs can be caused by plantar fasciitis. Heel spurs can be caused by plantar fasciitis because of the attachment of the plantar fascia fibrous band that's attached to the periosteum, the lining of the heel, okay? And that the way that the way the plantar fascia is being pulled is in the elongation or the positioning of the osseous, the spur, bony overgrowth is at the inferior calcaneus, and exotosis is the bony overgrowth, exotosis. And it will go into the alignment that this is being pulled. Now remember, this is a lateral view, so it's going to look like a hook or a sharp tack. 50% of the people with plantar fasciitis have heel spurs as an end result. The primary problem is plantar fasciitis. The pain is most severe in the morning after the tissue has contracted during sleep. The plantar fascia supports the arch of the foot in carrying the weight of the body. Approximately 90% of women and 40% of men with plantar fasciitis are overweight. Plantar fasciitis is the most frequently used term for plantar heel pain. It's like a garden term that everybody uses like shin splints. For years, pain localized in this region has been incorrectly termed as a plantar heel spur. Incorrectly termed. The formation of a spur may be present but does not represent the cause for pain. If the foot flattens or becomes unstable during movement, this leads to stress of the plantar fascia and the attachment at the bone. Various diagnoses will be discussed, including calcaneal stress fractures, insertions of the Achilles tendonitis, calcaneal apophysitis, the growth plate, Sever's disease, peroneus longus tendonitis, sciatica, the lumbar region, fibromyalgia, and rheumatoid arthritis. Related conditions of heel pain syndrome can derive from heel spurs, plantar fascia ruptures, nerve entrapments, and plantar fasciitis. Factors that may contribute to heel pain. Yes?
I'm sorry, Donna, is there a visual with this?
Yes, there is. Have you gone onto the website?
Yeah, I've done that, and it just it's not going to any visual. So I just wondered if I was missing something. I am then.
Is there anybody else on the call that is not seeing the presentation?
I'll keep working on it. I'm sorry to interrupt then.
No problem. You let me know.
Thank you.
If you don't get it, I would call Tracy at the corporate office.
Thank you.
You're welcome. Factors that may contribute to heel pain includes increased daily activities, weight increase, or change in footwear. Those three main areas. Now remember, this is the majority of the time. Various treatment plans includes a foot and shoe assessment. The best shoe for heel pain will vary from one person to the next. Over-the-counter foot supports, modifications may vary on the over-the-counter. Appropriate shoe selections and custom foot orthotics. This plantar fasciitis frequently affects athletes, people who are on their feet all day, and those over 40 years of age. Among professional athletes, plantar fasciitis is one of the 5 most common foot and ankle injuries. If left untreated, the conditions could become chronic and can lead to a host of other issues, which we're going to discuss as we go further. The presenting symptoms, patient usually describes pain in the heel on taking the first several steps in the morning, when the symptoms lessen as walking continues. They frequently relate that the pain is localized to an area that the examiner identifies as the medial calcaneal tubercle. That is the attachment area of the plantar fascia. Everybody has done this where you are palpating the calcaneus for the most prominent pain area, and this is the most common area for typical plantar fasciitis. The pain is usually insidious with no history of acute trauma. Many patients state that they believe the condition to be the result of a stone bruise or a recent increase in daily activity. It is not usual for a patient to endure the symptoms and try to relieve them it's not unusual for the patient to endure the symptoms and try to relieve this with home remedies for many years before seeking medical treatment. Wearing proper footwear for the activity or work you're participating in, ensure it is comfortable and there is padding. Sole stiffness. If you have a very flexible shoe and you have a plantar fasciitis, you do not want a very soft sole shoe. And sufficient arch support, especially if running or standing specifically. If purchasing new shoes, leave at least a 1/2 inch space between your longest toe and the inside of the shoe. Remember to buy them in the late afternoon as your feet swell during the day. Properly sized footwear made out of breathable and flexible materials will also help prevent against corns, calluses, and bunions. Try to avoid vinyl or plastic. Now, when I say vinyl or plastic, I'm saying that is directly to the foot. Plantar fasciitis. Foot devices or inserts may help to ensure proper cushioning. So when you talk about curved last shoes, curved last, if they have an excessive pronated foot, you never want to put them in a curved last because a curved last is more flexible. A straighter last is more rigid. So you want to put an excessive pronated foot into a straighter last shoe. Also, firm sole versus cushioning sole shoes. If you have an extremely firm sole that is proximal to, or firm EVA proximal to the metatarsal heads, then you've got a firm hindfoot and firm midfoot. And that controls excessive elongation of the ligamentous structures. It actually brings back the stability or the reinforcement of the joint ability. With a soft sole shoe, you normally have a higher heel, which if someone has a static heel cord contracture or natural heel cord shortening, this does help. But if they have an extreme pes planus foot, it does not benefit. Plantar fasciitis is a very common diagnosis of heel pain, usually caused from, this is usually the primary problem, biomechanical problems, such as overpronation, flat feet. The plantar fascia is a broad band of fibrous tissue that runs along the bottom surface of the foot from the heel, and you'll find that I'm going to repeat this a little bit as we go because I want you to know exactly what we're talking about. From the heel through the midfoot and into the forefoot. Those are the three areas of the foot we discussed. Overpronation can cause the plantar fascia to be excessively stretched and inflamed, resulting in pain in the heel. Overpronation or excessive. Someone turn their sander off. and arch areas of the foot. Often the pain will be most intense first thing in the morning and after prolonged periods of rest. The pain will gradually subside as day progresses. To properly treat heel pain, you must absorb shock. It may be in the heel, it may be midfoot, the metatarsal area. Provide cushioning and elevate the heel to transfer pressure. Now, that is your typical treatment plan, but I want you to keep in mind as certified pedorthist, you may not always evaluate the heel. It can actually, in evaluating the heel, if the problem is actually stemming from a depressed metatarsal area or displacement of the forefoot, that will cause a pull on the plantar fascia. So if you elevate the heel, that enhances the pull on the plantar fascia, which can lead to more exostosis. Visco heel cradling, PQ, PPT, all of that can be beneficial if it's a true plantar fascia inflamed from trauma a lot of times, but not a biomechanical problem. When the condition is pronation related, usually plantar fasciitis, an orthotic with medial posting and good arch support will control the pronation and prevent the inflammation of the plantar fascia. So the initial part that we were talking about, the properly treated heel, that would be basically in a acute inflamed heel from repetitive standing on concrete, if they are not excessive pronation. The second part, we're talking more of the biomechanical aspect. Then you want to look at the footwear selection as far as treating heel pain. Shoes with a firm heel counter, good arch support or firm midfoot base, and appropriate heel height are the ideal choice. It may be a low heel, negative heel. It may be a neutral to a high heel. It's going to it's according to each individual. A clinical exam provides more information about how your heel is being used by the rest of the body. As you stand, walk, and perhaps run, any point of maximum pain is considered. So like if they have initial pain with heel strike or as they toe off, you will want to take into consideration as to the mechanical needs of that area, what muscles are actually inserted in that area, and what joints you're actually working with in the articulation form of biomechanics. The alignment of the foot, bones, and joints are evaluated. The style and action of your arches, both on and off of your feet, are evaluated. The positions of your heel in stance and gait is observed. The foot and leg are checked for excessively tight or contracted or loose tendons for spastic, loose, or weak muscles. The flexibility or tightness of the Achilles tendon, heel cord is checked. Check for range of motion. If they have a loss of range of motion, tight Achilles tendons can actually initiate the pull and causing plantar fasciitis. As you observe them walk, only then can elements of a treatment plan be formulated and offered and pursued, okay? Through professional experience, it's taught me that the most common cause of heel pains is from mechanical forces. This could be a single blunt blow to the soft tissue under your heel. More likely is repeated excessive traumas, repeated micro tears of the plantar fascia to one or more of the heel tissues, especially that of the plantar fascia. This results in inflammation of the fascia and the periosteum, the lining of the bone. The inflammation and the pain, now you have to have an inflammation of the periosteum before a heel spur does ever occur, but remember that is a secondary problem. Inflammation and pain of the plantar fascia is called plantar fasciitis. Both the bone and the fascia can be inflamed, swollen, and painful, and usually involves the Achilles tendon, adjacent muscles, and fat pad tissue. If persistent, these forces can cause the formation of a secondary problem, bony spur under the heel. The finding of a heel spur upon x-ray is not the cause of the pain, but rather evidence that your foot has been malfunctioning for longer than your symptoms suggest. Very rarely does a heel spur have to be removed, and it will not dissolve majority of the time, even through the the osteoscans and the breaking up of the osteospurs. They will form. It is usually the inflammation that causes the spur and not the other way around. Related to Heall spur syndrome are not the same. Okay? Plantar fasciitis and Heall spur syndrome is not the same. Heall spurs are not spike-shaped but flat and shelf-like. They appear like spikes because the x-rays are taken from the side, looking down along the edge of the shelf, okay, the lateral view. Pain rarely, if ever, results from Heall spurs, poking into the tissue. That's a myth. People have Heall spurs, but they do not experience pain. A Heall spur and or the plantar fascia may trap or irritate nerves in the heel area, if only by inflammation. And this may be the primary cause of pain in some of the areas. It is often difficult and usually unnecessary to distinguish between plantar fasciitis and Heall spur syndrome, if there is a difference. Causes and treatments for the two conditions are the same. Many doctors use the terms Heall spurs and plantar fasciitis interchangeably. The phrase Heall spur is used more often than plantar fasciitis because a Heall spur can be seen on x-ray. The idea of a spur poking into the tissue provides a more believable and understandable cause of pain, even if it is a false description, and because it is easier to pronounce and spell than plantar fasciitis. Unbelievable. The Pedorthic task is to examine and sort this all out. Then make recommendations for your care. If symptoms and findings suggest that a medical problem is a significant component of your heel pain syndrome, then you should refer back to their primary care physician or some other specialist, rheumatologist, or while managing the footwear and foot support needs. So you don't want to lose managing the footwear and the foot needs, but you want to communicate with the referring source. If mechanical forces are to blame, the treatment focuses on relative rest of the foot and other long-term control of them. Mechanical control can include the use of relative rest of the painful foot, curtailing excessive activities, special stretching exercises of the muscles of your foot and leg, nighttime bracing of the leg, ankle, and foot, a change in your work style, duties, or environment, alternative recreational activities, swimming instead of jogging, use of the most appropriate shoes and avoidance of inappropriate styles, body weight reduction under MD supervision, tape strapping of foot with padding of the heel, trial use of commercial heel pads, cushions, or arch supports, custom-made functional orthotics for the best control of your foot function long-term. Heel pain may also have a neurological, traumatic, or systemic origin. Although pain may occur along the entire course of the plantar fascia, it is usually limited to the inferior medial aspect of the calcaneus. At the medial process of the calcaneal tubercle. The tubercle is nothing but for attachments. It's a bony prominence of the bone for attachments. This bony prominence serves as the point of origin of the anatomic central band of the plantar fascia, and the abductor hallux, the flexor digitorum brevis, and abductor digiti minimi muscles, the muscle that goes to the little toe. Calf stretch. This is a non-weight bearing calf stretch that would be very comfortable for you to do, and you can. It's non-weight bearing, so you're not going to overexert the components of the lower leg. But you sit on the floor with the opposite leg bent. You can see here to offload stress at the low back. The leg that you're stretching has to be out in front in the frontal plane. Okay? Both hands are below the knee. Lock the knee. Really extend the knee and then dorsiflex actively, unassisted. Actively engaging the anterior compartment of the lower leg. Therefore, really anatomically stretching the posterior or the Achilles tendon, gastroc, medial hamstrings area to offload contractures on the heel. 9 times out of 10, if they have true plantar fasciitis, This will immediately give them some relief, and you will see a change in their pressure scans. When we talk about stress fractures, that can be a component of heel pain. It's a result from a cumulative effect of repetitive micro-trauma that is insufficient to cause an acute fracture, but eventually leads to stress failure of the involved bone. Order of frequency, from most common to least common, of stress fractures is the tibia, second metatarsal, third metatarsal, fifth metatarsal, sesamoids, navicular, femur, fibula, and pelvis. Okay? If it's left untreated, stress fractures can progress to displacement with malunion and subsequent foot deformity or poor weight-bearing capacity. The etiology of plantar fasciitis are the result of, let's go back, biomechanical fault that causes abnormal pronation. For example, a patient with a flexible rear foot, varus, may at first appear to have a normal foot structure, but on weight bearing may display significant pronation. Talus with plantar flex and adduct are the calcaneus everts. This pronation significantly increases. This is the case, a chronic plantar fasciitis involving the right foot. And you can see the severe hindfoot valgus deformity. On the left, you can see that there's a slight arch raise here. On the right, there is more of a pronation of the talonavicular joint or mid, causing more of a lengthening pull or contracture pull at the calcaneal tubercle. Okay? Other conditions such as tibia varum, bow leg, ankle equinus, severe hindfoot varus positioning, rear foot varus, forefoot varus, compensated forefoot valgus, and limb length inequality can cause an abnormal pronation pronatory force. Increased pronation with a collapse produces additional stress on the anatomic central band of the plantar fascia and may ultimately lead to plantar fasciitis. This will also lead to inflammation of the periosteum, which can lead to a heel spur. This is understandable since the weakest point of the plantar fascia is its origin and not its substance because of the high tensile strength of the fascial fibers themselves. So wearing inappropriate footwear, like on a concrete surface, and a shoe that does not have a firm shank or midfoot control, then you're causing constant repetitive stress on the plantar fascia and mainly at the attachment. Okay? Lack of shank support in midfoot. This is a lack of shank support in the army boot. You can see the collapse of the midfoot, and there's more stress at the styloid process going to the metatarsal area. But with the midfoot control, the Cudsley boot, you can see that this has a firm shank and it will not let the foot collapse in this area. That is one of the key components of stressing plantar fascia. Shoe wear patterns. You can see the collapse of the wear pattern here on the flip-flops that this patient came in experiencing heel pain. Get her out of the flip-flops as soon as possible, more natural control of that foot. But even though they say this feels very comfortable, it is molded and contoured, but it actually causes the breakdown. And you can see why they would have more pain on the right medial calcaneal tubercle. Also a lack of base support at the heel. This is a patient that is complaining of heel pain on the right, but also has a lot of issues with her back. But you can see that her right heel is off of the mid shaft of the shoe. Also on the opposite side, severe collapse. Improving supported foot base enhances joint stability. This is a patient that came in that feeling a lot of ankle and foot pain all along the plantar surface of the arch, even into the metatarsal areas on both feet. By putting her into the Fin Comfort shoe would give a wider base, and immediately she feels less stressed. So by reinforcing the wider base. So if you could take a picture of your patient when they come in and then a picture in the appropriate footwear, that's always a good fact and selling tactics for you. Appropriate footwear selection by observing what they have on while they're standing and walking, and then observing what you put them in and the alignment. But have your camera with you. It's very inexpensive, and you can have immediately facts and information at hand. So hypermobility of the talonavicular joint can lead to a great deal of other problems, knee, hip, back. But we're talking, this is a patient with heel pain, diagnosis of heel pain syndrome from her orthopedic surgeon. On the right foot, you can see the right midfoot collapse. Posterior view, we see too many toe syndrome and the severe twist in this area. This is her standing in the shoe, putting her in appropriate footwear that same day with the Brooks Addiction Walker, and also modifying the old AmFit that she came in with to reinforce the foot. So what I did initially is taking the AmFit, I took 1/8-inch firm EFM material, extra firm material. This stuff works great. Get it in an 1/8 or in 1/4 piece, but an 1/8 really does offer a great deal of support, because the hotter this material gets, the firmer it performs, okay? So what I have done, this seems to be the main aspect that I'm wanting to control, is the midfoot and the forefoot, okay? I want to offload the calcaneus, because her pain is right at the medial cervical, but there is so much breakdown in the medial arch. So I've taken that. You can see where I've placed it on the medial plantar surface, and heat this up, not the orthotic, except this is put into with a hot gun or in a convection oven. Heat up to where it's very flexible, very, very flimsy, and then mold and hold in the position you want the foot held at. Then I will sand down the area and to accomplish the support that I want to accomplish. On this patient, I did use a medial skyphoid pad on top. I'm just showing you what I used and placed it right on top along with the black EFM, giving me a higher medial flare. And when I offer that, I offer more control. But you've got to have good heel control, because if you don't have heel control and you offer a lot of high medial support with that type of foot, they're going to slide off of the forefoot base. Orthotic devices that counteracts pronation and disperses heel strike forces will always be a key component of treatment for plantar fasciitis. The Pedorthic should perform a complete biomechanical exam, checking the range of motion of the first MTP, mid-tarsal and subtalar and ankle joints, as well in relation to the aid of the foot assessment for for any biomechanical abnormalities. So palpation of the medial calcaneal cervical usually elicits pain in patients presenting with plantar fasciitis. But believe me, do not try to enhance pain in this area. You know, you've been to doctors and they will poke the heck out of your foot until you're about ready to scream, and then they think that's where I'm going to inject the foot. Please don't put your patient through that type of discomfort. A lot of times they will point to the area. You can check for bony prominence, but please don't enhance the discomfort. To make the orthosis, the Pedorthis should cast the foot non-weight bearing, holding subtalar joint in the neutral position, neither inverted nor everted, or casting in standing semi-weight bearing, applying pressure at the inferior patella and controlling the amount of weight and position of the foot. This is with foam impression box. The initial non-weight bearing would be with plaster Paris or a sock, okay? Casting weight bearing or chair position with the use of foam impression, or casting the foot using the advanced biomechanical system incorporating plantar plantar flex first ray. These are the types of casting positions that you can use. And they all will be effective, but make sure that you select the appropriate one for the flexibility and the biomechanical needs of that foot. Casting performed in this position captures the foot deformity and allows for proper mechanic control. A properly casted orthosis will provide biomechanical support and diminish the abnormal compensatory forces that may subsequently cause plantar heel pain. Other causes of heel pain, less common causes of heel pain, should be considered before treatment regimen for plantar fasciitis is undertaken. These are sciatica, tarsal tunnel syndrome, and we're going to discuss these. Entrapment of the lateral plantar nerve, rupture of the plantar fascia, calcaneal stress fractures, neopophysitis. Rarely, systemic disorders can cause heel pain. When we talk about sciatica, sciatica pain can lead to heel pain. Heel pain is secondary to sciatica, is a result of pressure on the L5 lumbar and the sacrum, or L5-S1 nerve root, which provides segmental innervation to the posterior thigh gluteals, the buttocks, anterior posterior lower leg, lateral lower leg muscles, as well as sensation to the heel. This nerve root is also responsible for the plantar response, the ankle reflex. The sciatic nerve innervates numerous muscles along its course, and patients may experience weakness in any or all of them. They may also report sharp pain radiating down the buttocks and the posterior aspect of the thigh and leg distally toward the heel. Low back pain can be enhanced by collapsed arches, leg length discrepancy, muscle imbalance, a lack of range of motion of the foot and the ankle, the knee and the hip, or footwear. So you can see anatomically by a collapsed arch what can happen to the back that can lead to a disruption at the S1, L5 area, which is in this area, and it radiates down the buttocks and into the lower leg and into the heel. This lady came up at a diabetic conference to me and experiencing left sciatica, and she has a burning at the lateral posterior aspect of her heel at the insertion of the Achilles tendon, right in the area here. The left sciatica and left heel pain, look at her hip. You can see how the left leg is functioning longer. The left shoulder is internally rotated. You can see the arms hang. So you know there's a disruption that's going on here. If you have a patient that's coming in with this type of symptoms, contact the referring source or the doctor that she had seen in the past, and feel free to send him pictures of what you're seeing or a dictation of the patient that's come into your facility, and start a networking or a communication with that referring source. Also, with sciatica or with just typical heel pain, you want to evaluate your patient in a postural analysis. You want to look to see what the neck, the shoulder, the vertebral column, the pelvic tilt, the quadriceps, the hamstrings, the patella alignment, the knee angle, and the ankle and foot positions. And when you dictate, if you're into a handheld dictation, I would advise you to do this when you're seeing a lot of patients and want to communicate with your physicians. Dictate immediately into what you're seeing, or right after you see the patient, to have this to follow up with physical therapists and other referring sources. One thing that is very good when you're looking at biomechanics is to drop a plumb line, imaginary plumb line, from the center of the body down to the floor, just like what I've done in this manner. And you can see, in explaining to the patient, you can see how the right foot does not deviate away from the midline as much as the left foot deviates. So explain to me, has there been anything going on the left side? And that will open up some communication for you. The patient's lower extremities should be evaluated while the patient sits on the examination table or in your chair with the knees flexed. The neurological exam, now with someone that's having some nerve root irritation. The neurological exam should include testing of proprioception, sharp, dull sensations, reflexes. Specifically the plantar reflex, to rule out polyneuropathy or a number of neurological symptoms. Sciatica, or neuralgia can cause as causes of heel pain. The physical exam should also include the simple thigh leg raise, which, if painful, may indicate a disorder of the lower back. The treatment of the heel pain caused by sciatic root compression should be directed to the primary pathology, okay, which would be their orthopedic surgeon or physical therapist or rheumatologist. Let's start with tarsal tunnel syndrome. And I realize, be patient with me, I realize I'm throwing out a lot of information, but this is a topic that I love. I may actually break it into 2 webinars. But let's just see how this goes. We're going to start with tarsal tunnel syndrome. Compression of the posterior tibial nerve as it courses from the posterior aspect of the medial malleolus toward the anterior medial aspect of the calcaneus. The tarsal canal is a fibrous osseous structure bounded by the flexor retinaculum medially. It's the retinaculum that actually encloses the 3 tendons that comes right around the medial malleolus or posterior to the medial malleolus. The posterior aspect of the talus and calcaneus laterally and the medial malleolus anteriorly. The tendons of the posterior tibialis and the flexor digitorum longus and the flexor hallux, Tom, Dick, and Harry, as well as the posterior tibial nerve, artery, and vein. Okay? Those 6 components travel through this area. Compression of the posterior tibial nerve here may cause a burning sensation. During the sequence of the gait cycle, the foot strikes at heel contact on the lateral outside aspect. The arch then collapses to absorb the shock force. As the arch rises, which the heel lifts prior to toe off. This causes the nerve to roll or shift slightly to accommodate the changing foot posture. Trouble occurs when the nerve is not allowed to move. Thus, entrapment of the nerve occurs. This entrapment can be caused by space-occupying lesions, such as a cyst or rheumatoid nodules, scar tissue from a previous injury, like a sprained ankle, or tightness of the soft tissue around the nerve. As the demands on the foot occur, the nerve becomes strangulated. Include palpation of the course of the posterior tibial nerve from the proximal aspect of the medial malleolus, above the medial malleolus, distally toward the anterior aspect of the calcaneus. Patients may experience an uncomfortable burning that radiates proximal toward the calf, which is called the Vallex sign, or distally toward the toes, which is called the Tenel's sign. Tenel's sign, which is elicited by compressing the nerve at the point of entrapment, causing radiation of the pain into the tarsal canal and possibly into the foot. The second is a positive Vallex sign. This sign is positive upon percussion at the point of entrapment with a neurological hammer, causing migration of electrical activity, lightning bolt sensations up the leg and into the foot. And a lot of times just tapping your fingertips onto this area will elicit the same type of sensation. The third sign helps to eliminate the diagnosis of sciatica from the differential diagnosis. A positive Lesquet sign, straight leg raises, a Lesquet sign, indicates the sciatic nerve is involved. This is elicited when the patient feels pain upon raising the leg due to the tension placed on the sciatic nerve at the lumbar area. Some of the symptoms of tarsal tunnel syndrome are dull ache, numbness, burning, itching, tingling, stinging, sensations on the bottom of the foot or at the tarsal tunnel area. Many other pathologies, diseases may mimic a tarsal tunnel syndrome. Finally, the pedorthist should inspect the patient's hindfoot for any structural conditions that may alter the patient's biomechanics. An abnormal gait can create greater tension on the contents of the posterior tibial or the posterior tarsal tunnel, resulting in an irritation of the posterior tibial nerve. Treatment of tarsal tunnel syndrome is accomplished by resisting the forces on the tibial nerve, by taping or strapping the foot to eliminate or reduce these forces. An orthotic, if successful, should be prescribed for long-term control. And this is where a tarsal tunnel relief channel or a PQ relief or PPT relief incorporated into the orthotic is very beneficial at the midfoot or at the calcaneonavicular area. Let's talk about calcaneal stress fractures, pain with medial to lateral compression. If you take the heel and into your hands and compress medial lateral at the calcaneus, it can present pain if there is a stress fracture. If they don't have pain during that formation, then you know basically it's plantar fasciitis. Calcaneal stress fractures, acute heel pain caused by calcaneal stress fractures can closely the symptoms usually associated with plantar fasciitis. The history may reveal a recent abrupt increase in daily activities. They may increase pain, have pain during the compression of the calcaneus, and this type of illicit pain is rarely present in patients with plantar fasciitis. When we talk about calcaneal fractures or stress fractures, this is actually a type of fracture that I have seen in the past from a fall, a direct force of impact, where a guy fell off of his ladder and had a fracture of the calcaneus. You have to perform an offloading of the shoe after they come out of a cast. Sometimes they may have a pin that is calcaneus that is gone into vertical positioning. But also they will, if they have this type of injury, you know that they have posterior nerve compression. They may have a subluxation of the talus or a deviation of the navicular and the cuneiforms. So all of that is compromised or affected when you do have a direct force onto the calcaneus. Entrapment of the lateral nerve, of the first branch of the lateral plantar nerve, provides innervation to the abductor digiti quinti muscle, which is going to the little toe. Has been said to cause plantar medial heel pain. The entrapment usually occurs between the abductor hallux muscle and the quadratus, is a fibrous band that crosses over the muscles on the plantar surface, giving patients a burning sensation on the plantar aspect of the heel that is aggravated by daily activities and even persists as they rest. So palpation of this area may prove painful with a tingling sensation. This is a patient that I have seen that has a orthodesis and has severe lateral heel pain, and it was diagnosed, the heel pain, he had multiple traumas, but one of his symptoms was lateral entrapment of the cervical nerve, which is the lateral aspect that is contracted in the abductor minimized and the quadratus on the plantar surface. But you can see the severe positioning of his foot in equinovarus positioning and a lateral heel. And you see that there's no contact at the toes. So all the stress, all of his pressure is standing when he's just standing or resting. That's where most of his weight's going. You can see right here, you see the little indentation in this area, that is tissue. And that nerve will actually comes underneath, but it supplies all along this area on the plantar surface. So basically, a lateral lack of lateral foot support. You can see him off the base of the shoe in this area. By widening out the base of the shoe with a lateral flare and a shoe modification, a lot of times will give them immediate relief. But the orthotic that I used is a M-fit with a calcaneal cuboid block to help reinforce the lateral aspect and offload the proximal pain of the calcaneus, but also a medial reinforcement to try to support the mechanics or reinforce the dynamics support from heel to toe. And that he has done very well. Actually, he has done well with this over the past 3 years. When we talk about plantar fascia ruptures, and I have seen a number of these in my experience, and they are extremely painful. The rupture of the plantar fascia is an uncommon cause of plantar heel pain. Patients often report severe pain in the medial arch following physical trauma. Some patients diagnosed and treated unsuccessfully for several months with steroid injections for presumed plantar fasciitis. This is a patient that you have see here that has had an acute plantar fascia rupture. The foot will actually collapse. But by using the toe splints and reinforcing and actively engaging the flexor hallux, the flexor digitorum, and reinforcing the posterior tib, actually gives them some relief and offers them some support. Okay? Plantar fascia ruptures on physical examination may reveal a palpable deficit. You may feel a little indentation going along the plantar fascia contour, or a small enlarged area where swelling or some of the fibers has actually rolled up distally to the rupture. Patients also experience severe pain on palpation of the plantar fascia with maximal tenderness, generally distal to the medial process of the calcaneal tuberosity, the tubercle. Gait analysis usually reveals a significant limp that spares the affected limb. Treatment consists of immobilization with non-weight-bearing mechanism. Now, what I've used with this is while they're immobilized into a cast walker or supportive shoe, I usually fit them with a custom orthotic, unless they have severe swelling. Then I may wait till some of the swelling goes down. But there is some type of support reinforced in that boot. Let's talk about calcaneal apophysitis. It's a disease. This usually affects children between the ages of 6 and 10 and who are obese or extremely active. In most cases, the pain is located in the posterior aspect of the calcaneus and is more severe after athletic activity. Palpation of the posterior aspect of the calcaneus around the insertion of the Achilles tendon usually reveals local tenderness, and that is at the growth plate. Apophyseal is growth plate of the calcaneus. Itis is inflammation of that growth plate. Adolescents with this disorder may have a tight Achilles tendon with limited ankle dorsiflexion, which sometimes causes them to walk on their toes to decrease the pain. This is a case study that I did years ago, a little 10-year-old participating in soccer with extreme heel pain, and you can see the growth plate here and the disruption at the apophysis in this area. You can see there's a disunion here and a disunion here. There's a disruption, and you can see also where the plantar fascia is actually, you can see a little bit of inflammatory process is going on here at the periosteum. This is her standing. You can see how one foot's forward than the other. The right foot is the protected side. Left foot's back. From behind, you can see showing the same characteristics. You see the difference in the popliteal space and the calf alignment. So as she came in walking on the balls of her feet, her dad brought her in. I looked at her soccer shoes, where you could just roll them up into a glove. So most children's shoes in that sport does not offer a lot of support. So I had her to do a non-weight-bearing exercise. Her first footprint is this one here on the left. And I noticed that there is absolutely, in the middle is her right foot. There's absolutely no toe activity. You can see on the left there is some toe activity, more weight-bearing in the metatarsal area. After her stretching, You can see more toe activity, and immediately her heel felt much better. So you know you have stages of plantar fasciitis with Achilles tendonitis and calcaneal apophysitis. So there's actually three components that you talk about in Sever's disease. In fabricating, I did do a custom 3/4 length semi-rigid orthosis in this manner. I have used in the past with children either a semi-rigid or a rigid orthosis according to their weight and their flexibility. Heavier, I'm going to do a deeper heel cup with like a 2 to 3 millimeter polypropylene or subortholene. When we talk about systemic disorders, heel pain may occur in patients with various systemic inflammatory conditions, including rheumatoid arthritis. They may have a nodule there that is, and you have to offload that nodule, either by relieving in the orthotic, cushioning, anything along that line. But understand what they're doing biomechanically. They may have ankylosis spondylitis. That's in the back where the is actually slipped forward. The vertebra has actually sliding forward from the vertebral column. Psoriatic arthritis, Reiter's or Reader's syndrome, gout, Beget's syndrome, and systemic lupus, erythematosus, gonorrhea, and tuberculosis have also been implicated as causes of heel pain, but such an association is rare. Most patients with systemic disease present with joint pain and inflammation in other areas of the body, but symptoms may occasionally begin in the heel. Talk about ankylosis spondylitis is a long-term disease that causes inflammation of the joints, type of arthritis, between the spinal bones and the joints between the spine and pelvis. It eventually causes the affected spinal bones to join together. When we talk about psoriatic arthritis, it's an arthritis that is often associated with psoriasis of the skin. Erythematosus, SLE, is a chronic inflammatory autoimmune disorder. I'm beginning to where I can't speak explain. I apologize. It may affect the skin, joints, kidneys, and other organs. When we talk about Beget's syndrome, disease that involves inflammation of the blood vessels, it causes problems in many parts of the body. The most common symptoms are sores in the mouth, other skin sores, swelling of parts of the eyes, and pain and swelling and stiffness of the joints. And they are seeing a lot of stiffness and pain in the ankle, which is causing heel pain. When we talk about Reiter's syndrome, involves both inflammation within and around the joints, and particularly where ligaments and tendons attach to the bone. Reiter's syndrome usually develops following an intestinal or genital urinary tract infection and is more likely to occur in individuals who have a particular genetic makeup. For example, a young man who reports bilateral heel pain and who has a history of conjunctivitis or urethritis for more than 1 month may have Reiter's disease. Similarly, heel pain in a patient with a history of psoriasis and pain in the distal interphalangeal joints of the fingers and toes should raise the possibility of psoriatic arthritis. When we talk about Sjogren's syndrome, associated with connective tissue disease such as rheumatoid arthritis, lupus, and scleroderma. Scleroderma is connective tissue inflammation. Gland inflammation resulting in dry eyes and mouth, etc. People affected are 90% are female. This is a friend of mine that has Sjogren's syndrome and also Agent Orange from the Vietnam War. She has severe medial, heel, and arch pain, and you can see I've detected the area that she is experiencing pain. We've tried custom orthotics, everything. Nothing seemed to really help. So actually what helped was taking an over-counter insert. And I believe this is the FS 900. And taking plastozote, 1/4 inch, and sciving out the medial area, offloading this area, the navicular and tarsal tunnel, and then reinforcing it with plastozote. Now, this has to be done numerous of times, or you can encapsulate the area over a long period of time and prolonging the lifetime of the plastozote. But that seemed to work very well. So let's recap here. Heel pain can be caused by a variety of problems. Plantar fasciitis is inflammation of the plantar fascia. Bruised heel, fat pad contusion. Calcaneal fractures, calcaneal bursitis. Tarsal tunnel syndrome, and heel spurs. So when we talk about ankle talonavicular hypermobility, can lead to stretch or stress of the plantar fascia, causing pain at the the calcaneal tubercle. So in this case, a lot of times you might want to use a rigid UCBL orthosis. You might want to use a softer EVA UCBL orthosis, because anytime that you can encapsulate the heel and bring that natural God-given padding back around that heel, you can actually enhance more cushioning. Also, if you want to do something immediately and give your patient some immediate relief, is to take 1/4 felt, and I prefer the adhesive if you can, and skive the felt into a 4-foot pad. You're going to skive the area across the first and down the lateral, the 4th and 5th, and down the lateral border, the 5th metatarsal, and then skive down into the medial. So you're going to skive in this area laterally, therefore reinforcing this will be higher than the skived areas, which it looks like this. You can place it into the shoe, and you can see how it's skived across the, in front of the calcaneus, down the lateral border, off of the 4th, keeping it high just proximal to the 3rd and 2nd, and skiving off of the 1st to integrate plantar first ray. Therefore, keeping you reinforced. And that's a very inexpensive way of giving your patient some immediate relief, either by taking the sock liner out of the shoes and placing it on top. That's very beneficial. Also, I wanted to show you some medial arch strapping that has been very beneficial for plantar fasciitis. I've also used it for stress fracture of the calcaneus with athletes. But this is a very simple way of you have an arch anchor, and this you always pull up on the inside, lay over on the outside to keep from getting tight on the lateral outside. Your support's going to be medially. You start your strapping. This is a elasticon strapping. You start at the lateral aspect of the 5th metatarsal, go across Springer ligament around the heel, posteriorly, back up, contact here in this area, and do not pull the heel out of alignment. Pull up, cut off, and then lay over.
All right, bye-bye.
This is a talonavicular uplift that also helps with Achilles tendon, calcaneal fractures, tarsal tunnel syndrome. It just gives them a good enclosure type feel. This is a 4-inch elasticon that you start on the lateral aspect below the lateral malleolus, coming around the plantar surface of the calcaneus, splitting, the larger part going in front of the medial malleolus, the smaller going posterior of the medial malleolus, pulling up and then wrap around laterally. Also, with case studies with plantar fasciitis, this is an ankle that's unstable. This is the initial onset of this area, right at the tibia tubercle. You can see the disruption of the calcaneal cuboid and more pressure from his footprint. But also looking at his shoes evaluation, you know you've got to throw these in the nearest garbage, but it does give you some information. You can see the wear pattern of the liners of the shoes as to what's going on, and also include them on the evaluation. And it also helps you bring together your focus as to what type of materials you would actually use to incorporate a custom foot orthotic. And on him, I did use a combination of EVA materials. Also, this is a patient that has had a great deal of piriformis and sciatic discomfort. In noticing her evaluation, her first footprint, which you see here, her initial onset of heel pain, after talking with her over a long period of time, she said that she has a lot of problems with iliotibial band tightness, which is the connective fibrous tissue band that connects the anterior and posterior aspect of the thigh, going all the way up to the greater trochanter of the hip. And when that becomes tight, that can cause hip bursitis, or it can lead to piriformis syndrome, an inflammation in the buttocks area. By stretching in this manner is a iliotibial piriformis stretch, non-weight bearing. You can see here that that is actually what is causing the heel pain. After stretching, and with the toe splints, which I always did on my evaluation, you can see here the offloading of the medial aspect of the calcaneus. She could not believe how just that stretch had eliminated pressure. Also, when you get a tarsal tunnel syndrome, which we have talked about, the disruption, you can see how that this can all shift. Now, years ago, he has torn his soleus and the plantarius. And the soleus inserts here at the medial aspect on the calcaneus. You can see the retinaculum that is stretched in this area. See the thickness in this area? That is the interosseous retinaculum that is enclosing that. That can squeeze the peroneal nerve. Not peroneal nerve, posterior tibial nerve. This is his footprint. You can see the complete collapse. He has burning sensations on the bottom of his foot. His heel will burn whether he's on his feet or off his feet. But you can see on the left, he actually has more of a collapsed arch. So by doing a custom and-fit orthotic, it was something that was flexible, that I could also accommodate the nerve by doing a relief channel and filling that with PQ. Also, if you want to do something in store, if you want to just see if this is just an acute plantar fasciitis, you take a over-the-counter insole. A lot of times just by changing up the pressure of their feet will give them some break in the pain pattern. So by reinforcing with a metatarsal pad, by offloading the heel, actually will help with plantar fasciitis if you notice a depression in the metatarsal arch. But I always top cover that. And they do get better results when it is dorsally on the orthotic. It is more profound, whereas if you put it on the plantar surface, it is very slight, okay? And you don't change up the heel pressure. So you always, now remember, always make your orthotics or over-the-counter inserts look very receiving to the medical attention. So let's say that you wanted to take, you wanted to control midfoot arch or midfoot collapse. Then you can take an over-the-counter insert, check and make sure if the heel is stable before you start. If not, you want to sand it down, right down the center, starting at the posterior aspect of the heel, going to the center of the foot, and check that balance and make sure that that's level. Then from that, you always want to keep the insert level. You heat up the material that you're using. On this instance, I used a firm 1/4 crepe, heated up the material. I'm holding the insole, over-the-counter insole, at the center of the heel and at the metatarsal area to keep my foot, to keep it aligned and balanced at the heel, lifting up in the area that I want to reinforce. Now I'm checking this before I sand down. This is, see how level my orthotic is or the insert is before I start my sanding. The heel should be in good position before the sanding. Then your sanding technique is always starting at the heel and pulling towards you, going toward the ball of the foot. Never start at the ball of the foot and come toward your heel. It will never look right. And this is the end result that it should look. therefore giving you a medial support and a calcaneal support area. So that can offload a painful heel. Always check the balance and the alignment of the heel. Let's say you wanted to just put a heel stabilizer with a proximal first ray. A lot of times if they have an excessive plantar flex first ray, by reinforcing proximal to the first ray and the heel will be just enough to offload the contractures of the plantar fascia or the Achilles tendon. This is the way it looks on the back, and you can see that this is high medially, posterior, and laterally in the way that I've balanced my heel. It sets very well balanced, and you can see the reinforcement that it offers in the medial arch. It's not so abrupt. So this is something you can do immediately or until that you get your orthotics, or this may be successful in accomplishing the or resolving plantar fasciitis. But always encapsulate, make this look acceptable. This is one of our runners from Foot Solutions that had also a lot of Achilles tendon and plantar fascia symptoms. And looking at this at one of the races that I participated at, I could see how that the foot collapsed. And most of the stress is here at the cervical. You can see the forefoot abduction. The footprint shows the deviation at the calcaneal cuboid and at the calcaneal navicular, causing medial heel pain. Okay? Also, this is what I had to do with her orthotic. This is an abs. This was done in a advanced biomechanical acting technique, but it still did not accomplish the heel control. So we have a lack of heel stability. This is an abs. I'm going to show you how to offer more support here if needed. You can see how that the heel is elevated laterally, and she still or rolls in toward the calcaneal tubercle, causing a disruption of the plantar fascia. So what I did, I took 1/8 firm crepe. This is heated. You do not pick up the orthotic and place the material around it. You always keep it level, pulling the material up around your base. Then sanding from heel, posterior heel down, then I have a wider base heel. And that offered her relief. Okay? Haglund's disease, retrocalcaneal bursitis, falls into heel pain syndrome. This is a Haglund's disease here, a bony protrusion. It may be exostosis. It may be scar tissue. It may be the bursa that is thickened. It can be the Achilles tendon, but in this instance, it is the bursa. And what I did with this patient is to reinforce, when you reinforce the metatarsal and the toe area, flexor digitorum, you actually get a natural lengthening of the Achilles tendon, which can relieve some of the tension on the insertion. Basically what I did with her, she had already had 3/4 length orthotics. I modified her orthotics, the Amfit. You can see the pressure here at the heel. That's not exactly where her pain is, but that's where I'm seeing the heel slide. You see the heel pressure is not in the center. Her heel pain is at the medial posterior aspect of the calcaneus. So I used the rubber heel wedges. Okay, I started out on the lateral side, glue that down, and then you glue the medial. It will look like this. You want to start sanding from the center of the heel, going down toward the center of the foot. And this is what it looks like at the end. And always encapsulate. Do not let them get out of there looking like this. When you put the encapsulating material on, you do not pick up the orthotic and place it on. You place the orthotic on top of the material and pull up around, stabilizing the heel. Also, rubber heel wedges on custom orthotics. Go ahead and do this on all kinds of orthotics. It's beneficial. I have seen a number of plantar fasciitis patients come in that have had, that are in the abs or the CBAS. orthotic, still experiencing severe heel pain. But on the evaluation, I'm noticing that their heel base of the orthotic is not wide enough to offer them to support. It's too narrow, and it's real wide in the forefoot. So this is one way of adding additional heel base, and that's taking us according to how much width you need. But on this one, I needed 1/4 inch firm. I used firm because this is a firm orthotic. I did a wraparound. Make sure your glue is on there good and firm, or contact. Get this very flexible and do a wraparound in the position you want that. Now, this is the base of the orthotic. You can see the wraparound on the heel base, and then I sand down the base. And that gives me the wider heel base, which you can see. You can see the finished base here. And that immediately gave them relief. And what it was is inappropriate heel base. This is, when we talk about trauma, this is a car accident, hit by a drunk driver, also a high school principal. And you can see multiple injuries, has actually almost lost this right leg. She has been in the New Balance, I believe this is the 992s, not the 992s. Never mind, I'll think of it in a minute. But the straight last with the elevated heel. And that has worked for some time, but her heel pain is very severe on contact on the right leg. This is her with her shoes off, and you can see the skin grafts that's been done. She's had open compound fractures from the injury. And you can see how that the ankle actually sits in valgus. Most of her heel pain is medial and lateral. So it covers the whole heel. She said it's just extremely painful. So on my evaluation, I used the toe splints because I saw that there was no activity in the toes. But this is her standing on the I-step. This is her initial scan, her left foot. You see there's not a union on the left side dynamically. You can see on the right, all of her weight is on the heel. She does not use the rest of her foot. So by using the toe splints, we started coming in with more of alignment on the calcaneal cuboid, the fifth, and the medial or the lateral aspect of the MTP and the great toe. But then you can see there's more pressure here on the left. So after seeing that, I reinforced with just metatarsal pads is all they had at this site, and at the calcaneonavicular and at the calcaneal cuboid, padding this with the toe splints. Now you can see what happened to the footprint just with this and the alignment of the foot. Immediately she says, I feel more stable on my foot. I feel like I can bear more weight. What I've done is actually offloaded the heel base by reinforcing distally of the calcaneus and the toes. So before the toe splints and pads and after the toe splints and pads, significant improvement. So basically what I did a custom orthosis with the calcaneal cuboid block and calcaneonavicular reinforcement. The application of rocker sole shoes, she went into the Chongqing and has done very, very well. I also made a second pair of abs with the same characteristics. And she has done very, very well. That has been a year and a half ago. Also with Sue Boscos, experiencing when she was training for a marathon, experiencing lateral heel pain, perineal and lateral knee pain, all down this right side. It started here at the inferior lateral aspect, the ankle, all the way down the perineal and the lateral base of the heel. And you can see from the right side the difference here. So look at her shoes. You can see the varus positioning of the calcaneus. This is her orthotics. You can see the wear pattern here at the base of the fifth metatarsal, the styloid process. And you see the lack of wear at the calcaneonavicular. So all of her weight is from the heel down the lateral aspect. So she's a true supinator. but she stands, well, in just standing as a pronator positioning. So she has a hypermobile subtalar joint. So basically, one thing that I did with her was reinforce, and I did not take pictures the day that I reinforced her orthotic, but this is another one with the same characteristics and the same thing that I did. I took a small cuboid block or a skyfoid pad, thinned this down, placed lateral of the calcaneus, and enclosing the cuboid, now proximal to the styloid process or the base of the fifth. And I did a lateral wraparound of EFM material. You can see my EFM material is 1/8 EFM, and heated that and did a wrap, starting here and wrapping it all the way around to the side up to the top of that. Okay, you can see what I've done here. And then shape that into the orthotic. Always coming back and stabilizing. This is a stabilizer. Just by putting this material on the bottom of the heel and not sanding that down does not offer a hill of beans. I've seen this a number of times. Please stabilize the heel. Start from the center posterior, going down to the center in front of the calcaneus. And that will give you high medial, high lateral, and lock the calcaneus in for medial lateral support. Subluxing perineal tendon leading to compression of the nerve, lateral nerve. And you can see the thickness and the inflammatory process, the subluxing of that perineal tendon in this patient. A distance runner, these are the shoes they're in, and you can see the severe supinated characteristics on the left. So an orthotic and this with this type of component, let's say that you have an abs that is severely inverting the foot. Then this is something that you can do by using a rubber wedge placed laterally. You can see how I've sanded down all the way around, skiving into the contour of the orthotic, leaving it high laterally. This is the lateral aspect of the orthotic. I'm going to top and encapsulate. This is it on top. This is it topping material.
Oh, you're learning it.
Well, we
Either have laterally, not taken away medially. And what I've done, if they do pronate severely and you do a severe, or if you do an ab technique of foam impression and you have overcorrected the mole, so they have a tendency to slide out and they feel it just cutting into them, this is something that you can do instead of trying to lower the inside. When you feel like they need that support, you can add more support laterally.
Okay, I don't know if you want.
This is a case study that I've done that I would like to show you. This is the last thing. Is left medial heel pain, severe, left stress fracture of the third metatarsal, left stress fracture of the second cuneiform, left piriformis pain, onset of left foot pain since 1993. You can see her left foot. She's been in the Brooks aerial, still having more pain on the left than on the right. I did the foam impressions in semi-weight bearing with inferior patella pressure to help align the foot in functional neutral. Scoring the plaster molds. This is what I wanted made. It was a 3/4 length UCBL blue, 2 millimeter subortholon or plastic polyurethane with low UCBL characteristics, and I wanted 1/4 crepe heel stabilizer on the left. Why? Because the left foot went into valgus more and the left leg functions shorter. So with the molds, I directed the lab to do an intrinsic cutout of the metatarsal arch coming down into the medial arch. You can see what I've done, and I've done that bilaterally. Metatarsal in between the first and fifth, proximal to the second through the fourth, down into the medial arch and across the medial aspect of the calcaneonavicular area. Molding the 2 millimeter plastic This is what it looks like after molding just the plastic on top. That way to stabilize the heel. Vacuum pressing the heel stabilizer, I used a firm crepe. Making sure that it still sets level before I sand. Standing down, keeping balanced.
What are you doing?
And it still sets level. Now we're ready for topping.
I was wondering if you guys have...
You can see here that the heel is actually wider than the forefoot, just due to the mechanics of the foot. If the heel base is too narrow, you're going to lose the control of the heel.
Yeah, there is a dent.
I thank you. I challenge you today to take in considerations everything that I've given you. I know I've given you a lot of stuff, but this is close to my heart. I hope I've given you some information that you can take and use. Good luck. There's no greater challenge than when you challenge yourself. God bless you all. Bye-bye. Are there any questions?
Yes, hello?
For somebody local,
Hello?
either in Flower Mound or...
Hello?
Hello?
Yes, just a quick question.
Sure.
Oh, great presentation. Thank you very much.
Thank you so much.
And will this presentation be recorded and put on the Foot Solutions FootNet?
Yes, it will. I want that done because I gave you so much information. It would be great to go and, scan it again.
Very good. That's great. Appreciate it. Thank you.
You are so welcome. Good luck.
Thank you.
Thank you.
$24.99.